Hello, my name is Michael Garrett. I'm a psychiatrist and psychoanalyst on the faculty at SUNY Downstate Medical Center in Brooklyn, New York. With the advent of chlorpromazine in the 1950s, chronic psychosis, diagnosed as schizophrenia, came to be viewed as a genetically determined brain disease best treated by medication. However, in the last 2 decades, research has shown a high correlation between a history of child abuse and psychosis in adolescence and adulthood. Roughly 15% of the general population report a history of child abuse. This number rises to 50% in people with a history of psychosis, and in some studies approaches 90%. These findings have sparked a renewed interest in psychological treatments of psychosis. All psychiatric residency programs provide in-depth training in the diagnosis and pharmacological management of psychosis, but few provide comparable training in psychological approaches. Rarely are residents taught how to carry on a conversation with a psychotic patient who has a fundamentally different view of reality than they do. This is a telling limitation in psychiatric education, given the high percentage of patients that residents are called on to care for that carry an Axis I diagnosis of psychosis. Psychotic patients are difficult to engage. Research into what actually happens in the consulting room between psychotic patients and their psychiatrists shows that typically patients want to talk about their psychotic experiences, while psychiatrists would prefer to talk about medication. Like two ships passing in the night that don't connect, patient and psychiatrist talk at cross purposes. At SUNY Downstate, residents are taught not only to diagnose and prescribe, but to listen to psychotic patients with an intent to understand the meaning of their psychotic symptoms. Residents receive 20 hours of didactic teaching about psychological approaches to psychosis, plus individual supervision. In the interviews that follow, you'll hear residents respond to questions about how they first got interested in psychiatry, the point of view that they had about psychosis when they began their training, the impact that psychological training had on their treatment of their psychotic patients, and the effect that this training had on their emerging identities as young psychiatrists.
Psychiatry happened in medical school, but psychology, I always say, like, I'm 10 years old and everyone's coming to talk to me, and I don't know how this happens, but everyone's venting, and I found it really interesting to hear people's stories. And so I think I became interested in something psychology related back then. And so when I went to college, I majored in psychology, and I envisioned myself being a therapist, like sit on the couch and like listen. I went to medical school. I had gone in trying to approach every rotation openly, like I didn't have a bias towards psychiatry. So I went in, and then it was my last rotation, and I always relive this, but I stepped foot onto the inpatient unit, and I just felt like I was home. Like it just felt like this is sort of where I needed to be, where I belonged. I was really curious about psychotic patients. I just found their behavior really interesting. I found the capacity of the mind to produce like a disorganization and sort of the delusional systems I thought were so, how does the mind do this? A lot of suffering coming through their story, which I also felt surprised by. Sort of a comparison comes to mind. It's like I used to think about my patients, like depressed patients was in one category, someone with like overt trauma, that it felt like this was like I envisioned a person with like a lot of doors sort of lined up behind them, that I was very clear path that was always supposed to go there and explore the things that were sort of leading to this person that was sort of in front of me. I didn't feel that before for psychotic individuals. I didn't even know if there was a door. I'm not sure what I saw, but now it's very different because I see them the same. Like there are so many doors that I can go through and so many places to explore. I became really curious to know about their story because based off of what they experience on a day-to-day, I understood that there had to be a story, that everyone actually has a story, that just because you're psychotic and it seems like you're sort of out of touch doesn't mean that you didn't live. Some of the things that we learned in our lectures about how our internal experience is sort of projected outside of us, really it's our experiences inside that we're experiencing as if they were coming from the outside, toward us, and how that encourages me to understand my patients on a deeper level then, because I know that it's coming from their internal world. I have a patient sitting in front of me, and I might hear what their experiences are, and my automatic question today is sort of like, how did this happen? Before, I think my explanation was more curious about the biological explanation, like what are their genetics like, and what's you think about like the dopamine hypothesis. I know that the answer is maybe in one of those biological explanations, probably has something to do with it, but that if I don't sit and listen and try to understand their story, that I would not then have an answer of how did this happen.
I know that you're a person who responds at an emotional level, to your patients. And I would imagine that could be complicated, sitting with a person who has the amount of suffering that comes through, in a psychosis.
Mm-hmm.
Tell me about that, about sort of how do you stay emotionally tuned in? In what ways do you feel moved in a somewhat different way than you were thinking more biologically and diagnostically before? It must be difficult in some ways. Yeah.
It is difficult. There are some moments that are much harder than others. It's most of the time when I envision what their life is like on a day-to-day, because it's one thing to hear what their experience is like. It's like they're telling me a story. But when I understand that this small piece of them that they're sharing with me, that it's hard for me to wrap my head around, just even within the hour that I'm sitting with them, that's their life every second. When I go there, it becomes particularly difficult for me. And I think that's when the suffering really comes through. I try to not necessarily do that during the session. And I think that I try to stay with them in terms of what we're talking about, but it's always there. And I think that's how I can connect to them, because I do try to understand what their life is like on a day-to-day. I just don't dwell on it, or else I can't be there for them. I try to stay intact for it because they need it.
The psychological thinking about psychotic patients, does it add or change your satisfaction in your work? And does it change in some way your feeling about what it is to be a psychiatrist?
I feel quite different. Well, I think on a basic level, I feel more useful to my patients. I feel that I'm giving them sort of what they deserve, whereas I think before, not having this way of approaching them or thinking about them, holding them sort of in my mind, I couldn't have been doing everything that I can do for them. And so now I feel by looking at them as a whole person with layers to them, I can be more useful. Yeah, it is more satisfying in that way. Mm-hmm. I also find it really wonderful to learn, like circling back to the beginning. I've always been fascinated by how it's really devastating, the stories that led to this sort of the type of thinking or the everyday persecutory experiences that we call interesting. There's a person experiencing them behind that. It makes working with the patients quite rewarding, I think.
Can you tell me something about one of your patients and keeping in mind confidentiality issues?
Sure.
But, just give us a feeling for one of the people you're working with and how they've come into focus as a person more.
I'm taking care of a patient who's in her late 30s, and she came to me after being hospitalized for a few months on the inpatient unit. And before then, I learned, was quite ill for approximately 8 years. No one had noticed. She had isolated in her home and was plagued for years by her sort of persecutory experiences that were, I came to learn, very much related to her earlier life trauma, which is pretty extensive. And so she's somebody who, this is, when I think about her, it's heartbreaking to think about her life on a day-to-day, because doesn't get a break. She doesn't get a break. She's, her sexual trauma history comes back to her in various forms, wherein she's raped in multiple different ways, by objects, by smells, by her own mind, her thoughts. She gets something she refers to as intellectually raped. Persecutors that she identifies disrupt her ability to feel any type of joy, even something as basic as reading the Bible, which is one of the most basic sort of sources of happiness that she gets. So I've tried to understand her experiences today further through learning about her life and her lived experiences, which have been really difficult for her, and which she's managed to put away, which has managed to sort of put away when they showed up in her psychotic experiences. And they follow her every day, everywhere she goes. And it's something that I think about her is that she's just so resilient, because when she describes her day-to-day, this is something that I've never really had a patient who was as ill as her. I think her voices wake her up from her sleep, and they try to deform her face. They gather in packs when she's trying to shower. And so she uncovers her body inch by inch, I should say, so that they don't see her exposed body and rape her more. They're constantly chattering. She calls it background noise. So she doesn't have any peace of mind. I think one of the hardest things about her delusional experiences is that persecutors have labeled her as somebody who's crazy. And so as a result of that, to not further feed into this, she's stopped her medications and her experiences. And I think that the chance of her, functioning to the degree that she used to, because she was extremely high functioning, she has her MBA, I feel is harder now. And so, but she's engaged, and she comes to therapy every week, and she finds it rewarding. So she says that she's understanding parts of her life that she forgot were there.
We've talked about your patient before, and I think I'm just underscoring what you're saying, that she had some experiences early in life of sexual abuse, and though she tries to consciously forget those things, she remembers them every day. They just flood all of her experience, and she feels intruded upon from every direction and every form.
We provide our psychotic patients with an opportunity to understand themselves by being curious about their lives and meeting them wherever they let us meet them, and to not discard our psychotic patients because they're psychotic, because I think sometimes that, we can, if we don't know the possibilities, which is, I think, what this therapy, or knowing about this therapy in this way of visualizing, conceptualizing our psychotic patients, we don't have that. It can be, I think, a little bit intimidating to try to approach the psychotic experiences and kind of know what you do with them and how you can help. But I think focusing on the fact that it's in line with this recovery-oriented treatment, that we're trying to sort of nurture our patients back to themselves by staying with them and showing them that it's possible. So something else is that I've always thought that being a psychiatrist is one of the greatest privileges, because we are allowed into the spaces these very sacred, private spaces that our patients let us in on. And so being able to learn about our patients through this, in this manner, I think just to me emphasizes like what a privilege it is.
I had thought I was going to be applying to OBGYN, and then went out and did a month working on the streets in Pittsburgh with the street medicine team, and loved that, and thought this is what my future is going to be. I mean, my introduction to someone with schizophrenia started when I was very young because my uncle has schizophrenia.
Wow.
And so I knew from afar what that meant in some ways. And a lot of what that was included thinking of some of the things he said and thought or behaved as sort of crazy, which was a bit dismissive in some ways, and also having a lot of sympathy for him and some of the things that he went through, being homeless, being shot, being in prisons, being in state hospitals, and also feeling a lot of sadness. So I brought some of those things into the idea of what an illness like schizophrenia has. The idea of where it comes from or came from in my mind at the beginning of residency was it runs in families, which it does in my family, and just bad luck. And the idea of how someone, like the treatment of what it is to treat psychosis or schizophrenia was medications, and a lot of times forced medications, like what happened with my uncle. And once he finally got in a situation where that was a required thing, he seemed to do a little bit better. Mm-hmm. But it was still kind of dismal. And it was a little bit difficult at first to interact with people who had the diagnosis of schizophrenia because I felt a little bit hopeless. He's actually doing pretty well. Great. He was on clozapine for a couple decades, and he did pretty well with that. And recently, through a lot of discussion with family and his psychiatrist, he switched medications and is brighter, has longer conversations. I recently wrote something that included him and his perspective in it, and interviewed him for a while along with other people in my family, and he really enjoyed it. But one of the things that was said frequently when I started was delusions are really hard to treat. You can't really touch a delusion. The medications don't touch the delusion. And that's kind of where it stopped. There's been a few other occasions where I remember, even this year, someone who I respect saying kind of dismissively, like, I don't know why we bother with this type of stuff with them, or I don't know how this would be, worthwhile for this person, or the meaning of some of the person's psychotic experience. It allowed me to see the patients as more full humans, having a very full experience, and not just sort of a two-dimensional, dismissive, you're crazy. It made me definitely think of, when I'm with patients, how much time I spend with patients who have schizophrenia, chronic schizophrenia, instead of doing like a 15-minute appointment, allowing myself to expand that and listen more. Mm-hmm. I think I'm very motivated to help this population, but coming in, it was, I'm charged up about getting them housing and making sure they have jobs and build up a community and have them feel supported. But I still didn't think about really considering the psychological component in healing and part of it. And I think slowly I'm doing that in my practice a bit more. Uh-huh. I do have one patient actually that I happen to see today, and I've been seeing every other week for about 6 months. That's been really rewarding. He is someone who's young, 24, has diagnosis of schizophrenia and a lot of hospitalizations. He's someone who had been working with the resident before and had some groove speaking about this, doing CBT for psychosis, and picked up with me. And after a few months of just kind of building rapport and feeling kind of comfortable with each other, told me a lot about this really disturbing, overwhelming idea of belief that he had of it, that his penis was shrinking, and that everyone knew that this was happening and would make fun of him, and that he would be yelling sometimes in like the room about how much this had bothered him. And so we've been working together, and over the last probably 8 to 9 months, the concern about that has gone down a lot. Even today, he thinks, maybe it shrunk a little bit, but it's stopped. The thing that's come out underneath all of that, which has been extraordinarily meaningful, is that he thinks of himself as a very broken person, and he has a very low self-esteem. He was beaten by his dad. He went to a private school and experienced a lot of racism, very overt racism from the people in the school. He hadn't really recovered from those experiences. He also has scoliosis, had major back surgery. And so for many things, he thinks about his body and himself as being just a broken person. And that's what we've ended up exploring a lot more of than just the initial issue. And now he's working, and he's going to Fountain House, and there's a lot of great things happening, especially after this experience with this gentleman, where I think they would do well if I gave them the time and I had more time to listen and figure this out with them. But it's a struggle to find it sometimes. I think it offers a much richer patient care experience. From what I've learned, it's a very effective mode of treatment from what I've seen, even with this patient.
Yeah.
The intervention went way beyond just the medications he was receiving. Having this interaction with him has changed a lot of the thinking that I've had with patients who have schizophrenia and what I hope to maybe do in the future. And if I hadn't had that experience, I haven't had the teaching, then I wouldn't really likely have considered any of it. I also think from a larger perspective, psychiatrists, of course, should be doing it, but it's always a team approach. And I think that psychologists should be doing it. Social workers should be doing it. Yeah. That perhaps even in the guidelines of treatment, this should be something that's required to at least be offered. We had talked a little bit, I think you brought up the idea of treatment resistance should include some form of CBT for psychosis or therapy. So yeah, I think absolutely it should be included in residency and beyond.
I was a late comer to psychiatry. I did a lot of time off after med school and worked in cancer research. So when I went to med school, I thought I would end up in oncology. That was kind of what I thought I would do. But my psychiatry rotation was by far my favorite of my clinical rotations, and which really caught me off guard. I honestly really liked the patients and the people. I thought the field, everybody was just so kind and interested and genuine. And I loved having the time to get to know the patients and the stories. I just loved, and that there was so much about psychiatry that we still don't know. It felt very like this unknown frontier, which is also was like drew me to it. We're taught early on very much the biological basis kind of psychosis and other diagnoses. So I came from thinking that, that schizophrenia and psychotic spectrum disorders being more biologically based. And coming in too, I thought, we have our DSM criteria of all the disorders, and you go through and you diagnose. And I think after being in residency, I think one of the biggest frustrations for me was it's really a lot of patients are hard to fit in those boxes, and the diagnoses are much more, feels like much more of a continuum of symptoms. And at first I was really frustrating because it felt like, well, how am I supposed to treat patients if I don't understand the diagnoses and fit them in these boxes with the treatments? But really over time, I realized that every patient is so different. And so every treatment plan is individual to that patient. And that's where getting to know them and understanding kind of what would benefit the patient the most, and not worrying so much about the diagnoses. Every psychotic patient I work with has been very different from the next. So it doesn't even make sense to try to, there's no one size fits all treatment. So I feel like that's made it a lot easier, at least for me, to conceptualize how to go about treating patients with psychosis. I also remember early on in training kind of being taught, like, there's the psychotic symptoms of hallucinations, etc. And, they meet so many. And so we put that in psychosis. That's fine. And not really listening to what patients were saying, what their delusions, what the content was. And I definitely had some supervisors who really taught me to sit down and listen to what the patients were saying and use that to build a rapport and trust and really get it, but not in so much a therapeutic way, I guess. There are people who just said they have hallucinations, like, we don't need to worry about what the content is. But definitely throughout my later training and our courses dealing more with the psychotherapy for psychosis has taught me really to listen very carefully about what patients are saying and hear them. And that's really changed how I've interacted with patients. And I think even for patients who aren't willing to or can't do true psychotherapy, it still is so helpful in building that rapport and trust and understanding them. And also, I mean, in all honesty, it's fascinating to hear what patients have to say. And it's really interesting and very non-judgmental way. I think patients appreciate it so much. Like, they don't really have many outlets for someone to listen to them talk about their symptoms like that. So absolutely. I think from day one, I feel like I've been lucky that I really like what I do and I love training to be a psychiatrist. But it's fascinating that as time goes on, I like it even more. And I really do enjoy the challenge of working with patients with psychosis. And I think it's a privilege to be able to work with them and listen to them. And I honestly I think it's like the best job in the world. I also feel like I learned so much about myself from my patients and how, vulnerable they can be is really powerful. And having the training and supervision to discuss with my co-residents and supervisors about patients is some of the most valuable time to really enjoy those discussions. And I really do love being a psychiatrist. I have one patient in particular I worked with throughout the year, her diagnosis being schizophrenia, possibly schizoaffective. She had some depressive symptoms come up this year. And she's in her mid-30s, was diagnosed in her late 20s, so has been dealing with it for 7 or 8 years, has been hospitalized a number of times, but has been stable for about 1.5 years out of the hospital, but really struggles with chronic auditory hallucinations that are very derogatory and bothersome to her and refractory to several medications. But she has pretty good insight into her illness. She understands what schizophrenia means, and she can talk about her voices. And over time, in gaining her trust, she has a lot of trust issues about sharing about her psychotic symptoms and worries that, I might send her to the hospital because she really hates being in the hospital. But over time, she kind of realized that she could let her guard down a little and talk more openly. And as we built that trust, she was able to share more about what she experienced and how these voices kind of tormented her. And sometimes we're coming from a subconscious place of guilt and shame that she felt about her mental illness, about her not being able to take care of her 15-year-old son. not being able to work, having difficulty with romantic relationships. But it was really interesting just to hear her reflections on it. And she even would ask me some difficult questions about like when she was started dating again. When do I tell my partner that I have schizophrenia? How do I deal with this illness? Which were some very interesting discussions that we had. I definitely think that the training we got was extremely valuable and important and should be required. I do think we had very unique supervisors who are very skilled at giving us the proper training. So I feel very lucky about that because I think it's very maybe nuanced type of training. However, maybe as it becomes more utilized and studied and broadened its applications, maybe then people will see how important it is and be able to develop kind of a curriculum, a standard curriculum for it. Yeah, definitely. I mean, I think that, I am so grateful to have this. I wasn't aware of how important it was until I went through it. And I worry that other programs that don't get it, I think they definitely aren't as equipped to deal with psychotic patients for sure.
Yeah. I'd never thought of it this way before, but you're saying that had you not gotten the psychological training, you would have gone on and graduated and become a psychiatrist and kind of not know what you were missing. And that now you know what you would have been missing.
Yeah, exactly. Yeah. I remember when I first heard about psychotherapy for psychosis, I remember thinking, what does that mean? How would that even work? Aren't patients too sick to be able to do that? Before I understood kind of the vast range of patients who have psychosis and how the spectrum of the illness and then the spectrum of the treatments, and kind of where all of that falls together and basically why psychiatry is a specialty in and of itself, because it takes a lot of skill to kind of navigate all that. So it's just interesting thinking about back before I kind of understood it till now.
I first got interested in psychiatry my third year of medical school. I did not anticipate taking a liking to it, but I remember just feeling excited to go back to the hospital each day, just enjoying the opportunity to engage with patients in a different manner than I did in other specialties. My rotation as a third-year medical student was in the inpatient setting. The patient demographic was quite acute, so we had a lot of patients who were psychotic. I remember just being drawn to the content of what they were saying, but not feeling like I had the necessary tools to really unpack it, nor was I really given any instruction. The attendings that I did work with as a medical student wouldn't give much credence to the content of what was being said. And so I think I internalized that and carried that forward into residency. It's been a transformative experience during my third year to really shift the way that I think about psychotic patients and cultivating the level of understanding needed to dig into psychosis has really extended to understanding my non-psychotic patients as well. Having the psychological framework, being able to unpack the psychological framework that underpins someone's psychotic episode has also translated to my typical psychotherapy cases as well. In medical school, my perception of psychiatry had more of a biological bend. And I thought to be a good psychiatrist meant to just understand the ins and outs of medication, and that's it. Since being able to adopt a psychological framework to psychotic patients, it's really opened the door for me and cultivated a lot of interest in having more of a psychological orientation. And not only that, just understanding its utility and the power of having a psychological approach to psychotic patients. A patient who had been with the clinic and been a resident case for many years, and working with her has been quite challenging. I meet with her weekly. I usually have multiple phone calls with her between that before really understanding more of a psychological basis for her psychosis. I found working with her quite frustrating. She would repeatedly tell me the same delusional content. I didn't really have the tools yet to understand it, the beginning of my outpatient year. Now that we're towards the end of outpatient, it's really given me a lot more empathy and understanding. I can think of another patient as well who had more of a brief episode of psychosis. And I think had I not had this training, the treatment of this patient would not have been as exciting. It would have been a simple matter of prescribing a certain amount of medication, monitoring the patient for a little bit, and then eventually discharging them. But by understanding the nature of their psychotic content and being able to apply a psychological framework to it, we were able to have a very productive therapeutic relationship. He's not psychotic anymore, but now we have just regular psychotherapy, and we pull in a lot of what we discovered during his psychotic episode. I was concerned that his coworkers and his family were conspiring against him because he thought he was showing signs of a sexually transmitted disease. This translated back to the fact that he was molested for a pretty significant amount of time as a child up into his teenage years. And I'll never forget the moment when he was able to make that connection. He was just coming out of his psychotic episode. We had finally developed some insight together. And the satisfaction I felt from that made it worth it.
I first got into medical school thinking that I was going to be a cardiothoracic surgeon. I remember that the medical school asked the first years to write down their top 3 interests. And I remember writing down surgery, pathology, and psychiatry. And when I told that to my friends, they were wondering why, because they didn't have apparent connections to one another. But I told them jokingly that all 3 of them involved a deep dive into the pathology, more like a deep dissection into the source of the problem. And looking back, I have always been an introspective person, being aware of the thoughts that I have and wondering why I have the thoughts that I do, and wondering if other people would experience the same thing or how would they experience their own inner world. When I first came in contact with psychotic patients, it was very difficult for me to connect with them. They seemed to have experiences of the world that were so far out there that I just cannot fathom what they're thinking about or what led them to have those experiences. And it was easy to kind of categorize them as the other without knowing what I know now after having learned a lot about the psychotic process, how it's a spectrum of the experiences of the inner world. So yeah, in the beginning, there was a disconnect in understanding them truly. In the first year of residency training, I remember just starting out with DSM classification of all the illnesses, the bipolar, the affective disorder, and the psychotic disorders, schizophrenia being in the primary psychotic spectrum. And that was the basis of my understanding. But soon afterward, there was an attending who gave us a lecture on the phenomenology of psychosis. He introduced us to an article that talked about how the experience of auditory hallucination has to do somewhat with sub-vocalization. And that started to get me thinking about the similarity between my own experience and what psychotic patients would experience that we call auditory hallucination. And I think that was a start of understanding them a little bit better. Now I realize the experiences that the psychotic patients have are not so different from what quote unquote normal people would have on a day-to-day basis, but that it's just on a spectrum, and that it could be a response to trauma, which is very different from how I first conceptualized them. So the labeling of the other kind of dissolved over time, and my desire to understand their traumatic history and their ways of defending themselves from the painful emotional and cognitive experiences really grew. And I think I'm a little bit closer to having the ideal level of empathy that I always desire that I would have before becoming a psychiatry resident. I remember when I was going through interviews for psychiatry residency, people would ask me, what are the top 3 qualities of a psychiatrist you think they should have? And I would always say compassion, empathy, curiosity. And it was so hard to apply those 3 values in interacting with all my patients. I think it was easier to express them in working with patients with affective disorders, and less so with psychotic patients because of the lack of understanding of their profound pain that is so buried deep within. I can think of this one female patient that I've been working with for the past year and a half. She's a 50-year-old woman who has never been married, but has multiple children, about 4 living ones that we know of, and possibly more than that she's not in touch with. She has had schizophrenia for a very long time, resistant to treatment, but doing significantly better on clozapine and haldocanoate. When I first started working with her, she had already been a patient of the clinic for many years already at that point. And so I started working with her on medication management, seeing her once a month for clozapine therapy and haldocanoate injections. And every time she came in, her story was the same. She thought that she was pregnant. Every little somatic symptom that she became aware of, she associated that with being pregnant, even though 9 months passed by and she wasn't giving birth. And there were multiple workups in terms of her pregnancy, OBGYN being involved. There was no evidence whatsoever. And then I started to wonder, where does this pregnancy or delusion of pregnancy come from? And I started really going through her chart, going back decades to see where did it all start? How did she present in her earlier years, in her early phases of psychosis? And I realized that there was a tremendous amount of trauma in her life, multiple incidences of sexual assaults, both by her family members and by strangers, history of homelessness, physical abuse. And I distinctly remember that there was an account of her delivering a baby while she was in a state hospital. She was described to be in a very fluidly psychotic state during delivery. There was no more details about that, but I could just assume how painful it would have been to have to give birth to another human being while not being in a state to be able to enjoy that. And so I think my empathy really grew for her. And so I offered to speak with her more frequently on a weekly basis to hear more about her story. And she really opened up. But I think that me listening gave her a sense that I cared for her, that I wanted to work with her. To a certain extent, she examined her thoughts with me about her delusion of pregnancy, how her somatic symptoms could be related to other things than the delusion. And I could not cure her. And of course I couldn't. It had been years of building up that delusion that defended her pain. And I only came into the picture years later for a brief period of time. But I think that was a good chance for me to learn that there was so much inside a psychotic patient that could be really discovered with curiosity and patience and compassion. Now that I'm working with more closely with psychotic patients, I feel authentic to myself in terms of how I imagine myself to be as a psychiatrist. I think there was some process of evolution within my identity over the past 4 years, and now coming back around to look at the psychological underpinnings of the manifestations that I see. And so I see myself as being more whole and authentic in that way. I would have missed out so much if I didn't have this experience learning in depth about psychotherapy for psychosis, the autobiographical play of a patient, where the patient is the writer, and all the characters within the story are the metaphors of metaphors that contain the meaning of the patient's life.
Psychiatry was my first clerkship. I was familiar with other aspects of medicine, but I had never seen anything like what I had seen on the inpatient units. Auditory hallucinations, very odd beliefs, odd behaviors, disorganization. I had never seen anything like it. I always had psychiatry in my mind as the top contender. And it was really because of the uniqueness of it. There wasn't an algorithm to treatment, and that really appealed to me. There was a personal element. The other thing that I had was kind of a hopelessness about the condition. I thought of it more as kind of a terminal illness of psychiatry. I saw people get better well enough to be discharged home, but there was always the understanding, even among the psychiatric staff, that this patient will be back. And I even discovered that there are groups of people, like the voice hearing community, like they accept that this is what happens to them and they live with it. When I first came in, I was quite biologically oriented. My supervisors did pick that up. They would comment that you're quite good at psychopharmacology, but I received consistent feedback from different people that I need to be more psychologically minded. To be honest, I had no idea what that meant. And even worse, I thought that it was all a lot of hand waving. After having finished 3 years of residency, I guess I can count myself among the converted. I've been fortunate to do psychodynamic therapy with both psychotic and non-psychotic people. And there's also some things that have changed. I'm very attuned now to trauma as an antecedent to psychosis. The other thing that my perspective changed on was one of our didactic lecturers gave a talk on the Vermont study, the capacity for psychotic people to live normal, rehabilitated lives. And for me, that really was an eye-opener. I got some real good CBT techniques, and I feel confident now to gently push and confront patients about their experience. I have this patient, she's a 50-year-old woman with schizophrenia, and she has persistent auditory hallucinations, some bizarre delusions where she believes that she's involved in some kind of a wedding game where she's married to multiple people. Some of these people are famous. She believes that she's married to the late Kobe Bryant. I think before I really wasn't as attuned to the experience. When I got sign out on her, I was told this woman has very poor follow-up. She told me that Allah or God had commanded her not to come. Her father, Allah, had commanded her not to come. I think I've even developed a lot more empathy for that experience. I mean, imagine God talking to you directly like he did to Moses, commanding you not to come to clinic or to hurt yourself. I mean, that for me, that's quite moving. Per clinic policy, she should have been discharged, but I refused to discharge her. God is telling her not to come to clinic. But also I was able to, I developed a bit more curiosity. So why Allah? Why is it Father Allah? That's a kind of strange construction of God. He has no father and no son. With this curiosity, I found that her father was dead. He had passed away. And I think that maybe that in some way that this was some part of her longing for her deceased father. I shared with a patient an experience that I had. So in our course, we had been taught to try and normalize the psychotic experience by doing some very focused self-disclosure. So the self-disclosure that I had was I had heard my name being called. And to me, it felt like a very real experience. And the reason that it felt so real was because I have a very unique name. My name is Mahmoud. And only people who speak Arabic have been able to pronounce my name properly. And even really my family members are really the ones who can pronounce my name the way it should be pronounced. I've had close friends and loved ones who, their whole lives, they haven't been able to pronounce my name. And
there's always hope.
And to hear my name called in that way was very real. And I turned around, I stopped what I was doing, and I turned around to investigate because there is no one that I know of that can pronounce my name that way. And I think this helped the patient. This self-disclosure, I think it helped the patient to understand that this is a part of human experience. So I absolutely think it does have a place in residency training, especially considering that in my own training, that patients with psychosis was the majority of the patients that I saw. For example, medication adherence, it changes. It never stays the same in your mind once you understand the concept of resistance. I think also it will go a long way to combat the stigma that we ourselves as psychiatrists have for patients with psychosis.
Yes.
It's not really a hopeless cause. Something can be done. Patients can learn to live with their illness. They can learn to cope. They can learn skills. The same kinds of CBT skills that are afforded patients with depression should be afforded to patients with psychosis. Now, looking back, having known about CBT for psychosis, I feel I would have been at a disservice in my training having not been exposed to it. Like one small example I can give on the inpatient service, I had a patient, a young Black man, who would hear voices that he believed were being projected into his mind from the government. I think my initial approach was auditory hallucinations, they're all the same, medicate them away. Take pause and think about, why are you hearing the voices? Why you? What's so special about you? Why are you the recipient of these communications or this monitoring from the government? This curiosity builds curiosity in the patient. You can see them scrambling to develop an answer. Oh, it's because I'm Black. That's what he replied. I took a second, I looked around, and I gestured broadly, and I said, there's a lot of Black people here. Why you? And that also gave him pause, I think. And for someone like him, who had been hearing voices compelling him to jump out of his window, or else they would harm his family, that moment of pause, why me? Am I really receiving these communications? Is it really because I'm Black? This might save his life.
My father is a psychiatrist, so it's a field that I was exposed to already. So I got to see a lot of inpatient work, because that was what our hospital was mainly known for at that time. We didn't have a very big outpatient department. So the inpatient work, I got to see a lot of very acutely sick people and psychotic people. And that's kind of what led to my interest in psychiatry, because it was something I didn't understand fully. My questions were never really answered. So I remember being told to be careful, be vigilant, and it was something very different than someone tells you when you go on a medicine ward or when you go to a neurology ward. It was curious to me that, because when you actually go and see these individuals, for the most part, I didn't feel unsafe. I felt for them. They seemed very sort of disconnected from reality. And for the most part, they were very quiet and out of it. And I was always wondering, why should I be afraid of them when it seems like they are the ones who are afraid? Part of the reasons I joined psychiatry was to work with individuals who had psychotic disorders, and working at a city hospital. Level of acute exposure that we got to psychotic illnesses just kind of reinforced my desire to continue working with this population. Being exposed more to the idea of doing psychotherapy for someone with psychosis was pretty novel to me. And one of the big things that really stood out to me was how much self-disclosure really helps when you're speaking to someone who is psychotic. You can still find a way to relate to them. Learning how to self-disclose in that way was a really big learning curve for me, but also very rewarding. I think this is a patient that I think you and I have talked about a bit. She has a very, very low self-esteem, and part of that is the voices are telling her that she's wrong, she's unfixable, she's broken, she's weird. And one of the examples she gave me was that at age 12, she would be making these mud cakes, and then kids would make fun of her and be like, you're too old to do that. I remember telling her oh, I remember doing that. And she was like, well, yeah, you must have been 5 or 6. And I was like, no, I'm pretty sure I was 10 or 11. And she was like, really? You're weird too then. I never thought of myself as a psychotherapist. I used to be very biologically driven, but coming into third year, I think that perspective did shift, where I started to have my own therapy patients and learning how to be human with them and not just their doc. That really changed for me. And I do think that I've become more confident as a physician, knowing that I can still show some parts of myself in a professional environment, but not being overexposed and sort of not taking over the space for the patient. It helps them show me a bit more of themselves too, without feeling like they're like a lab rat or an experiment to me. Because as a class, like, we are taught this, and it's something that we benefit greatly from. So it is possible to do. Like, our program is an example of that. My own experiences are an example of that. And they are really useful when we take like our patients' experiences and we actually have a space to discuss them with someone who has like a idea of like what psychotherapy for psychosis is, and you're able to incorporate like techniques into it. It is something that I have personally benefited from as well, just as a budding psychiatrist, of understanding my patients a bit better and being able to engage them much longer than I think I may have when I was in a first year, as a second year, actually.
Thank you for your attention. I hope you found what the residents had to say interesting and enlightening. If you would like to learn more about training in psychological approaches to psychosis, please consult the Austin Riggs Center CME website for additional information. To all of you engaged in challenging but necessary psychological work with psychotic patients, be well.